Okay. I think, well, we all know that breast cancer is the leading cause of death in women, and scanning mammography is key to reduce mortality for breast cancer, but it has limitations, and in particular, a high false positive rate. So there is a real need for a non-invasive technique to improve the discrimination between malignant and benign breast lesions. Collagen proved to be present in different amount and type in malignant breast tissue as compared to healthy tissue or benign lesions. So sensitivity to collagen in vivo could be really relevant for diagnostic purposes. If we consider risk of breast cancer, breast density, the amount of fibroglandular tissue in the breast, is a strong independent risk factor for developing breast cancer. Actually, is the strongest risk factor apart from age. Nowadays, breast density is assessed visually from X-ray mammograms, so it typically becomes known at the age of 50. While it would really be useful to know it in advance to identify women that are at high risk early in their lifetime, to design for them dedicated paths for monitoring and screening, and also preventive interventions are feasible. And again, collagen is a major constituent of stromal tissue that determines breast density. And so sensitivity to collagen could be of interest also for the assessment of risk. And it has been shown in the literature that collagen seems also to be an independent risk factor. And this would make the direct in vivo assessment of collagen even more important. So this is the reasons that have pushed us to try to apply time domain diffuse optics to measure tissue composition, and in particular to assess collagen in vivo in breast tissue in particular. Okay, we operate in the time domain with a spectroscopic approach at multiple wavelength. This means that we inject picosecond light pulses into the tissue. Light propagates, is absorbed, diffused, and we collect either the transmitted or the diffusely reflected pulses, typically at centimeter distances. And this means that the attenuation is very strong, is a factor of 5 to 7 with respect to injected light. If we look at the normalized pulse, injected pulse, compared to the transmitted pulse in a typical real measurement, we see that propagation into tissue causes significant delay and broadening. If we interpret these changes due to propagation with a proper theoretical model, in our case, the diffusion approximation to the radiative transport theory, from a single measurement, we can estimate the absorption and the reduced scattering coefficient at that wavelength. If the measurement is repeated at different wavelength, here the spectroscopic approach is important, from the absorption properties, we can derive the tissue composition, while from the scattering properties, we can derive information on the microscopic structure of tissue. That's it. Okay, these are examples of absorption spectra measured in the red to near infrared from volunteers with different breast type. And if we see that if we consider progressively different breast type from more adipose to more fibroglandular tissue, the absorption properties change significantly. For adipose tissue, the spectrum is dominated by lipid absorption, the yellow spectrum, and then 30 nanometer, while for dense tissue, fibroglandular tissue, the absorption is stronger and dominated by water at 980 nanometer spectrum. And we also see, even though less apparent, the contribution from blood at short wavelength and collagen at longer wavelength. So qualitatively, we see the effect of tissue composition on absorption. This can be quantified to the very low. We measure the absorption coefficient mu sub A, a function of wavelength. We know the extinction coefficient, the specific absorption of each constituent, and we can estimate their concentration. And we do that for oxygen, deoxyhemoglobin, water, lipid, and collagen. The scattering also can be useful. There are no spectral features here, but the amplitude and the slope of the scattering spectrum provide information again on tissue composition. And they can be quantified with a very simple empirical approximation to mean theory, where the reduced scattering coefficient is modeled as a power law in function of wavelength. The amplitude A is related to the density of scattering centers, while the slope B provide information on the equivalent sites of the scattering centers. And scattering centers in this wavelength range, red to near infrared, typically means cell membranes and subcellular organelles. So also the scattering can provide us some diagnostically relevant information. Okay, with that in mind, we have developed our optical mammograph that I've shown you, that operate in the time domain at 7 wavelength in compressed breast geometry, well, same geometry that is used for X-ray mammography, but with much milder degree of compression. And the instrument was used in collaboration with the European Institute of Oncology in a study with a twofold aim: the optical assessment of breast density as a risk factor, and also the optical characterization of breast lesions to improve the discrimination between benign and malignant breast lesion. The instrument exploits a sources 7 picosecond pulse diode laser emitting between 637 and 1060 nanometer, pulses at different wavelengths are time multiplexed, coupled into a single injection optical fiber that inject the pulses a different wavelength into the compressed breast. The compressed breast is raster scan, moving the injection fiber and a collection bundle in tandem. The collection bundle collects the transmitted pulses, and it has a bifurcated distal end that sends the transmitted pulses to 2 separate detection paths for wavelengths respectively shorter and longer than 800 nanometers. And then 2 PC boards for time-correlated single photon counting allows us to collect the time distribution at the different wavelengths. We collect data from more than 200 subjects and analyze data on 86 lesions. For all subjects, we collected 4 images in craniocaudal and oblique view from both breast as routine designed for X-ray mammography, and we analyze the data as I described earlier to estimate the tissue composition, blood parameters, water, lipid, and collagen, and structural information that is provided by the scattering parameters. For the assessment of breast density, we have averaged all the information obtained from the different pixels of the 4 images because we're interested in an average characterization of the breast tissue of the subject. While for the lesion discrimination, we applied the perturbative approach to estimate the difference in absorption and then the difference in composition between the lesion and the average tissue in the same breast. And we compared with the gold standard Barrett's categories that I will discuss in a minute for breast density, and histology for the lesion characterization, and when not available for benign lesion mammography and ultrasound. Okay, let us consider the estimate of breast density as a risk factor first. Breast density is the amount, the fraction of fibroglandular tissue in the breast. Breast density is usually in clinical practice is usually classified using Barrett's categories 1 to 4 for increasing breast density. So moving from a very adipose breast tissue, almost entirely fat breast, to an extremely dense breast dominated by fibroglandular tissue, as shown in the X-ray images reported here. So moving from adipose to fibroglandular tissue, increase in breast density corresponds to a significant increase in the risk of developing breast cancer. If you compare women in Barrett's category 4 with women in Barrett's category 1, Barrett's category 4 women have a 4 to 6 times higher risk of developing breast cancer. So breast density is a significant risk factor. What we measure, okay, here you on the x-axis, we have the increase in density, so increase in cancer risk, and on the y-axis, the concentration of the tissue constituent that we measure, water in this case, and we see that for increase in breast density, we measure a significant increase in the water content as expected based on the increasing amount of fibroglandular tissue, and this obviously corresponds to a decreasing, progressively decreasing amount of lipid tissue. Upon increasing breast density, also the collagen obviously increases. And we have also investigated the slope of the scattering spectrum because based on measurement that we performed on different tissue types ex vivo, we have seen that the slope of the scattering spectrum depends on collagen, to the amount of collagen in tissue, and also potentially on the structure of collagen in tissue. And we see that the slope of the scattering spectrum also increases progressively with breast density. So we have two parameters that depend on collagen content, and also structure, the scattering slope, and they both correlate with breast density. So we just simply multiply these two parameters, and we obtain a good correlation with breast density. So we have a non-invasive way to measure breast density, and in particular to identify women that are at high risk, women in Vital's category 4. If collagen will prove to be an independent risk factor, this estimate will be even more important, obviously. Okay, so now we want to identify women at high risk, so women in Vital's category 4 as compared to other women. Look at the parameters that we measure. All parameters we measure are significantly different for women at high risk. Higher water, lower lipid, higher collagen, higher hemoglobin content, higher scattering parameters. Only blood oxygen saturation is not significantly different. But we have 6 significantly different parameters. So we looked for the best logistic regression model using these parameters, the best model to identify women at high risk, women in Vital's category 4, and the model turned out to depend only on collagen content and scattering parameters, which in turn depend on collagen. So collagen really seemed to be the key tissue constituents to identify women at high risk. This is a ROC curve that we obtain with the standard threshold of 0.5. We are here on the ROC curve. This means a specificity of 94% and sensitivity of 69%. The sensitivity is low, but okay, it would be obviously nicer to have a higher sensitivity also. That we have to consider that this is not a diagnostic application. Here we want to identify a group of women that are at high risk. So a small group of women that are all at high risk, and that they will be monitored during their lifetime. Okay. So in this case, specificity is even more important. It should be favored with respect to sensitivity. Let us now consider the second application, the second aim of the study, that was the optical characterization of breast lesion to discriminate between benign and malignant. On the left, you see examples of ligated intensity images collected at a different wavelength, detecting only photons within a selected time window on the tail of the transmitted pulses. On the tail, because late photons remain longer in the tissue, have a higher probability to be absorbed, so they provide at least a qualitative information on the absorption properties. Different constituents absorb at different wavelength, and so these images gives us a qualitative idea of tissue composition. And we see blood at short wavelength in the red, and let's say below 800 nanometer. Then we see lipids, water at 975, and collagen at 60 nanometer. But then we can quantify tissue composition in constituent maps that quantify the concentration of the different constituents, and we can compare what we obtain, for example, with the X-ray images as reported here. Here we have this adipose breast. We see it's almost entirely translucent to X-ray, and we see it also in the optical images. The lipid map shows a high amount of lipids in the entire breast volume. There is the residual of the mammary gland, which is also seen due to the high content of water, and well, it's noisy, so it's difficult to appreciate, but also there is also a higher collagen content, and there is this blood vessel, which is seen in the X-rays because it's calcified, and we see it with a high content of oxygenated hemoglobin, suggesting that it's an arterial vessel. So we have information on the physiology of breast, and then we can also quantify the concentration of the different constituents in the lesion region, shown here, as compared to the surrounding. And we have done that for malignant and benign lesions, and we considered the difference in composition between lesions and average tissue in the same breast. And we see that for all lesion types, both benign and malignant, in the lesion we have higher blood content, lower lipid, higher water, and higher collagen as compared to the healthy tissue. This is true for both malignant and benign. It's more marked in malignant lesion for collagen and close to significance for blood content. But we also see some difference, even though not statistically significant, also on the other constituents. So we try to exploit all these differences together using a recursive binary splitting followed by adaptive boosting to try to improve the cases that were initially misclassified. And we did that considering tissue composition that we measure by optical means and the other risk factors that are always known from the anamnesis of the patient. And if we look at the importance of the different parameters in the discrimination between malignant and benign breast lesion, we see that tissue composition is more important than other parameters of respect of that we considered, and collagen is again the most important tissue constituents to discriminate between malignant and benign breast lesions. And we achieve a sensitivity of 93% and specificity of 88%. It was just a very small initial study on 86 lesions, but that obviously need to be extended and confirmed. But it was, well, a good start that moved us to the SOLS project. This is an H2020 project that aimed at improving non-invasively the specificity of breast cancer diagnosis to a multimodal approach. We combine B-mode ultrasound scanning, conventional ultrasound imaging using clinic for morphologic information, shear wave elastography to measure stiffness, and diffuse optical tomography to measure tissue composition, water, lipid, and collagen, and physiologic information on blood parameters. And we used the morphologic information provided by the ultrasound to guide diffuse optical tomographic reconstruction to improve the quantification of tissue composition in the lesion. Each of these three techniques has already proved useful to some extent for breast cancer diagnosis, but none of them is good enough to be accepted and used as a standalone diagnostic technique. So our goal is to combine the different pieces of information provided by the three techniques to try to achieve a more specific non-invasive diagnosis of breast cancer. And to reach this goal, we have developed a multimodal tomographic imaging probe, handheld probe with the ultrasound transducer in the middle and 8 measurement points for optical measurement around the ultrasound transducer. Each of these 8 optical measurement points is what we call the smart optode because they correspond to a standalone device to perform time domain diffuse optical measurement at 8 wavelengths. And this has to fit in a very small footprint because we want to be able to collect the information from different light paths and image the same volume that is imaged by the ultrasound transducer. And this has required the development of each component from the picosecond laser driver to the fast-gated wide area silicon photomultiplier detector to the acquisition electronic to fit in this very small footprint. Now the system has been completed. We started from an ultrasound imaging system and we had the capability to perform the multimodal measurement with the handheld probe that we developed. Now the system is in clinic. We have collected the initial data on a few initial patients just to give you an idea. This is case of a malignant lesion, a 2-centimeter carcinoma, which is seen in the ultrasound image. We draw the contour that is used to guide the optical reconstruction. We acquire the shear wave elastographic data, and we see that this malignant lesion is characterized by significantly higher stiffness than its surrounding tissue. And we obtain the optical reconstruction, and from the optical reconstruction, we estimate the tissue composition in 3D. This is the water map that we obtain online, and we can scan the volume in the 3 direction to see the changes in composition as a function of position. We have a higher water as compared to the surrounding tissue in this lesion, lower lipid content, higher collagen, and higher blood content, higher hemoglobin content. This is qualitative, and then offline we perform a refined analysis to better quantify the lesion composition. This is just an example because it's, well, we have just few patients. We are now continuing to collect data to then be able to perform a more sounder analysis, a statistical analysis, and combine the results of the three techniques, obviously. I would like just to add some information on another technique, on another application that we are testing, and that is on neoadjuvant chemotherapy for breast cancer. Neoadjuvant chemotherapy is more and more widespread, is widely applied
to
reduce the tumor size before surgery, or even in the best case to avoid surgery. But the problem is that approximately 50% of patients do not respond to the therapy, and this becomes known only at the end of several chemotherapy cycles, because there's no optimal imaging modality for this application, for this for neoadjuvant chemotherapy. So our idea is to test the time domain diffuse optical imaging to monitor neoadjuvant chemotherapy, and also, if possible, to predict very early the outcome of the therapy. For that, we are using the optical mammograph, where we have upgraded and improved the detection chain, because we wanted to achieve a higher signal level at long wavelength, especially because long wavelengths are important for collagen quantification. So we replaced the old detection chain, we replaced the photomultiplier with a silicon photomultiplier probe with the 8 silicon photomultiplier detectors with a high sensitivity, and this allows us also to remove the optical fibers. And we are now using a time to digital converter with high throughput to be able to collect a higher signal in the measurement. The measurement are performed in collaboration with Ospedale San Raffaele, and along the chemotherapy cycle, we perform optical measurement baseline before starting off the chemotherapy. Then we have a couple of measurements in the very first few days that we hope could help us in the prediction of the therapy outcome. And then we keep monitoring during all the chemotherapy cycles. Just again, as for Solus, just an example, because we are at the beginning, we only have few patients, so it's just a case study. This big lesion, almost 6 centimeters in diameter, before starting on chemotherapy. After the chemotherapy sessions reduced to less than 3 centimeters. So the patient was a responder in this case. And what do we see from an optical point of view? Okay, here you have on the y-axis time, so the optical measurement and the corresponding clinical events, medical events, so chemotherapy sessions on top. And on the y-axis, the concentration of the different tissue constituent that we measure. Lesion was in the right breast in blue, and the contralateral is in red. So total hemoglobin decreases very rapidly in the first days of chemotherapy, and in the breast with the lesion, but we also see some decrease in the contralateral breast. Less marked, we start from a lower value and the change is lower, but we see some changes also in the contralateral breast to show that the therapy is now locally as a systemic therapy. We see in the region with the lesion a very strong and rapid change. Blood oxygenation decreases in both breasts and then shows some increase in later time. This was observed also in some cases by other research groups, this trend with an initial decrease for responder and then an increase at later time, and deserve to be further investigated. If we look at tissue composition, water starts from a significantly higher level in the breast with the tumor and decreases progressively to the baseline of the contralateral breast. Lipids, similar thing. They start from a significantly lower value, increase very rapidly, and go to to the baseline value of the contralateral, and similarly for collagen. But what is important is that we see the change that is due to the fact that the patient is responding, and we see it very early. So we see it in the very first few days. So this seemed to be a suggestion that the prediction of the outcome could be possible. It was just as I mentioned, a case study because we are at the very beginning. And these are the people who contributed. And well, the first study that I discussed was performed in collaboration with the European Institute of Oncology, while Solus, and this work on neoadjuvant chemotherapy is in collaboration with Hospital San Raffaele. Thank you.